Καλησπέρα σας. That's the only Greek I'm going to be speaking tonight.
Με συγχωρείτε πολύ, δεν ανέφερα, αλλά το καταλαβαίνουμε. Έτσι είναι, μαζί συμπροεδρεύουμε με την Ελπίδα την Πάβη. Έτσι δεν είναι, και μετά θα αναλάβει να συντονίσει.
Again, good evening. I would like to start by thanking Aris for this kind presentation. And I would like to start this talk with a small anecdote, a small story. You all know David Crockett, right? The man with the gun. So once upon a time, David Crockett and his friends went through the great American prairies looking for buffaloes and Indians. And since buffaloes were not many left, they only could find Indians. And after a while, they found a large, full-fledged war Indian camp, 5,000 Indians. So his friend said to Dave, Dave, what we are going to do? Dave collected his thoughts, thought for a couple of minutes, and after that he said, I have a solution. You take him from the right, I take him from the left, let's surround them. Now, this sounds very much the sort of thinking that many of our healthcare reformers have, which means with a couple of speeches, with a few laws, with a limited budget, with a community that hardly understands anything about health systems, and with us, even with us, that have a very limited, fragmented, and biased understanding of health systems, they want to surround the Indians. And the Indians do not surrender. So, given this obvious fact, a year ago, some people, many from industry, approached us and asked us, can you do something to improve collective intelligence? Is it possible that you academics, other than doing the small studies you do something larger and build a system that will improve our collective intelligence? Well, that's a challenge, and we started working on that a year ago, and that's what I'm going to present to you tonight. So, the main idea is that can we, in fact, work on a system that we call it collaborative intelligence, that is people-centered, value-based, integrated activation. And I use those words, people-centered, value-based, integrated activation, because in fact, they represent the major elements of the future of health. So let me explain you very quickly what this collaborative intelligence in fact is. Well, we select some specific tracer conditions. From those we derive action profiles, and we try to share these profiles with all stakeholders, with citizens, providers, healthcare delivery systems, industry, and government. And of course, as you understand, this sharing has to be specific to stakeholders. Let me explain this a bit more in detail. So we took 10 tracer conditions selectively. From there, we summarized them in 6 main dimensions. And finally, we try to communicate these dimensions, these profiles, to different stakeholders in a way that enhances the desire to act, influence the way they think, influence the way they may behave. Okay? That's the basic concept. And I will, during the presentation, I'll be presenting to you the main theoretical references of this approach. These are some: collective intelligence, some call it the internet global brain, knowledge brokering, visual thinking, and metaphoric language, some of the key pillars of this sort of project. You will see other references as we go through the presentation. Now, I told you that we have basically 4 dimensions to describe the health system. And I'll tell you which dimensions are those. First, health, community health. If you will, health through the life cycle. Health during our life course. That's the first element. Of course, during our life course, we need healthcare. We need healthcare processes, and that's healthcare process, second dimension. As we go through healthcare processes, we interact with technologies, with technological innovation. That's the third dimension. And finally, the fourth dimension is we ourselves, people. What do we feel? How do we think? How we behave? What are our attitudes towards our life and health as a whole? So those are the 4 basic dimensions. Now, of course, you need a 5th one that deals with the context of the health system, the national, international context. That's 5th dimension. And finally, all these need to be governed. So we have both government and the principles of good governance. Okay? So this is the structure of this collaborative intelligence system. Now, as you understand, this system generates many profiles according to stakeholders, according to time. What I'm going to present here tonight is the profile I prepare for tonight. It's different from others. It's not a Greek profile, of course. I cannot do that. Some of you may do that. But it's specific for your audience tonight. So it's a selective one. You don't want me to be speaking for 2 hours, right? So I have to be very selective to give an overall view of how we can look at our system in a way that's conducive to action. Okay? Let me start. As we say, the first one has to do with our life course. What happens to us during our life? Now, recent authors, that's one way you're looking at. I can design this in many different ways. That is a selection of issues that we confront during our lifetime in health. Recent authors, as I was saying, have argued quite well, quite intensively, that this life course approach has at least 3 great advantages. First, allow us to look at intergeneration relationships. Second, focus on critical time periods where we want either to intervene or to prevent. And finally, allow us to look at the cumulative effects of our potential of well-being as we go through life. Okay? So let me illustrate each one of these advantages of looking at this dimension of health in this particular way. Well, first, intergenerational effects. If we have middle-aged working families that impoverish or get unemployed, the effect on health is not on themselves only, is in their children and in their parents, not only in terms of health, but also in social protection. The same happens if younger generations migrate to other countries. They affect the well-being and social protection of the ones that are left. So it's important to look at from that intergenerational aspect. Now, the second one is to critical times. I selected 3 critical times to show you. The first has to do with child poverty. Now, in Portugal, current data show that 1/3 of the children are growing at risk of poverty or exclusion, 1/3. Now, this is not only important because of the suffering associated with chronic stress at the moment they are growing, but also important because now we know that that sort of chronic stress in children is associated with the loss of functional memories that do not allow to continue to learn as you grow up. So, as somebody said, this sort of poverty goes straight into your brain. The second example has to do with depression. These are the data in our country on depression. And this slide is quite interesting. You all know that depression is a noisy diagnosis. So you have to be a very strong phenomenon underlying this table. So from a very noisy diagnosis, you can get such a straight line trend. And the third example has to do with old age isolation and dementias. You know, of course, that isolation by itself, physical, cultural, emotional isolation, is one of the risk factors of dementias. In the city where I lived, 1 in each 4 persons aged over 65 live alone. And the ones that live not alone, 60% of them live with people of 65 years and older. Now, dementia is certainly a big challenge. We know for European data that the age group of 90 years of age, 1/3 of men and half of women almost are to have dementia. And certainly we need to understand, we need to ask the question, are we getting prepared for that phenomenon that is coming quickly upon our communities? So, finally, the accumulated effect of our life course events. What is our health at age 65? How many years on average, are we expected to live after 65 years of age healthy? So probably you know the figures. They are not very interesting to look at. So a woman in Sweden at age 65 has 14 years of healthy life on average. A woman in Ireland, 10. A woman in Spain, 6. In Greece, in Spain, 8. In 6. And in Portugal, 5. This is not only the fact that you get sooner than others the effect of disease, but also countries, wealthy countries, have the opportunity of living more years healthy and therefore spending less money on health, while less wealthy countries have this early disease phenomenon that not only signifies suffering, but also makes health more expensive in these particular countries. Okay, so that's about the first dimension. This is health in our life course. Okay? As you notice, I select issues that ask questions to everybody, to providers, to citizens, to politicians, to industry. What is your answer to these challenges as they are presented? Now we go to the second dimension. This is about the process of care. Now, we all know that we have a strange way of thinking health systems. We think on primary care, we think in hospitals, on long-term care, and public health separately, as different management, different organizations, different management, parallel vertical thinking. Now, this is very strange from the patient's point of view, because what people need, what people want, is to go from one station to the other easily, comfortably, with good results. They don't care whether you call it hospital or health center. For people, normal people, they want to have access to care and to transit from one organization to the other one comfortably, timely, and with good results. So it doesn't make much sense in terms of health system to just concentrate on managing organizations. What probably should manage is the process, the trajectory. How we say it in Greece, the trajectory? Sinomi? Right. Right? So what we need actually to start managing is this process of care, is the way people go from one organization to the other ones, with what results at the end of that. And that is what we call, this is an interesting photograph, downtown Lisbon. Somebody wrote in the wall, we do not cross borders, borders are imposed upon us. And that's actually what we are constructing in the way we look at our systems. Now, so what we need is something like that. And that effect is a value chain. At the end of each process, at the end of this trajectory, the question is how much value we obtained, which means how much health gain for unit cost you achieve at the end of this trajectory. So, of course, we manage hospitals and health centers, and they need to exist so can have trajectories. But what we need is, instead of focusing on organizational management, is in focusing in this trajectory across them and on the result of this trajectory. Now, 20 years ago, we couldn't do that because those are virtual organizations. But today, we can do relatively easily. It's not very difficult to be able to trace people across organizations and ask the questions, did they get a fair deal at the end? Okay, let me give a theoretical background. Michael Porter, as you know, is well known as the one American scholar that most work on chain values in health. And the basic formula is value is health outcomes by cost of delivering these outcomes. So that is the question about what is the value that we obtain at the end of this process. Let's give you a few quick examples of what we mean. Now, we know that in our country, people with depression, 40% of them did not manage to get health care before a year is passed. Now, we need to present data this way because it asks a specific question. How come depressed people, 40% of them, wait more than a year to get medical care? And we answer to these questions. Those questions are expressed in a way that require an answer. Second example, retinography. Now, if you compare the data of retinography between the two bigger Portuguese cities, Porto has twice as many per inhabitant retinography than Lisbon. Nobody can understand why, but it's important to know because retinography is a key element on quality of care of diabetic patients. So we need to express a question so we can press for an answer and for correction of this particular problem. Third example, lethality for pneumonia. Southern hospital in the country has twice larger lethality from pneumonia than northern country hospitals. Nobody can explain why. We need to know. In our country, every single day in the National Health Service, 81 persons become inpatients because of pneumonia, and from those, 16 die. Very important problem. We need to know how they die. Last example, the case study in this case, 3 weeks delay of a stroke patient after discharge before starting rehabilitation, unacceptable. So we need to know how many people do wait 3 weeks for rehabilitation after hospital discharge with a stroke. And we need an answer, why is this and how can be corrected? So let's go to the third dimension that has to do with innovation, innovative technologies. Now, through our life course and through our healthcare processes, we interact with health technologies very frequently. And my point is here, there's no reason why you don't have access to the full data on the value chain of technology you interact with. Okay, let me give an example. We can talk about the exciting communication information technologies. We can also talk about the God-challenging biomedical technologies, right? They are all over us, and they continue to be. But the question is the following. Okay, when you look at technologies, and now I'm focusing on drugs, you usually look at financing, prescription, and utilization, right? And it's very important that you look properly. Let me give you an example. This is the evolution of expenditure with oral antidiabetics in the country. In 6 year times, expenditure for antidiabetics went from 58 millions to 107 millions. This is a threefold increase. Now, I'm sure that novel new antidiabetics were profitable, were useful for many diabetic patients. But there's no evidence that of this threefold investment, there was a threefold increase or twofold increase or 50% increase on the health of the community. And we have to ask the question, what's the relationship? Why we invested 3 times in 6 years in oral antibiotics, and we can't find any evidence that the investment resulted in better health? But my point again is that this is not enough. Looking at those 3 elements of the value chain doesn't give the full picture. We need to be able to have access, not only as professionals, but only as citizens, to the full cycle or value chain of innovative technologies. What is the value? It looks something like this. And there is no reason I can find why me as a person, both professional and citizen, cannot have an access of all elements of the value chain of the technology I interact with, whether there are diagnostic technologies or therapeutic technologies. Now, one of the advantages of looking again at the full cycle of the value chain is that I can displace my attention from the usual spot for much earlier in the value chain processes. We know together, to know all now, that we can know quite a lot about the technology of the future if you look at them 2 to 3 years before they're introduced in the market. We just cannot wait as public authorities that appear in the market to start thinking about it. We have to know in advance which are going to appear and what we do with them. A recent example is recently from UK, where public authorities start discussing with the industry what to do with antibiotic production. So they cannot wait anymore to find out the industry is not producing antibiotics. They have to start negotiating 3, 4 years, 5 years before, at the early stage of the value chain, in order to make sure that 3 years from now, 4 years from now, we have technology we need. Okay? Now, let me come to the 4th dimension. This is people. Now, most of us, in our formulae, in our tables, very often don't represent people. It's a given. It's something that's implicit. Doesn't matter what kind of people that we have. And sometimes it's interesting to see that we go to Finland and we see a very interesting organization, and we ask the question, why we don't have that organization in Portugal or in Greece or in Italy? And the answer is very simple. We are not Finns. We can have the organizations that our culture allows us to have. We cannot invent just new organizations because we think about them. We have to have the culture. We have to have the sort of attitudes, the sort of knowledge that allows that sort of organizations. Okay? So let me go quickly through people, very quickly. First of all, we have the basic notion of health literacy. And those are the main people that over the last 30 years are working with the notion of health literacy. I must say that in order to be short, I prefer operationally the concept of people activation, how you activate communities, how you activate people. From a first phase that start to have an awareness of a problem, second phase where they have enough information and knowledge. Third phase, we are able to decide. And finally, where they can learn from decision, they can learn how to continue to decide in more intelligent ways. Now, I will submit to you that the level of activation of our community is strongly related with the kind of organizations we can have. We cannot have advanced modern organizations with inactivated people. It won't happen. It never happened in the past. It won't happen in the future. So if you want modern organizations, you have to invest in people. You have to invest in the activation. There's no other way around it. Now, 2 words about organizations, very quickly. This has to be quick, because you have to have an overview. I cannot stop in a specific topic because you lose the entire picture. Now, those are typical organizations on many of our countries. The old doctor-patient relationship in his consulting room, and the public bureaucracies. Public bureaucracies have a lot of people waiting and a lot of hierarchies internally. That's what characterizes public bureaucracy. So what we have basically is public bureaucracies and old-fashioned one-to-one relationships. Of course, this one is fading away, and the bigger bureaucracies are the ones that predominate. So where we go from here? Now, the new child in the block is this one. Transnational private organizations. We have at least 2 public hospitals in Portugal that are run by Chinese and American organizations today. And that trend will increase. These transnational organizations are very powerful. They buy local private organizations, and they establish large chains across countries. This is the new kid in the block. And Paul Starr, a very known American sociologist, has studied 30 years ago how these new organizations look like and how they're characterized. They are large, transnational, strong efficiency focus, industrial consultation, multi-level operations, and distant intelligent decision-making focus. This is the main characteristic of these organizations. So in fact, our challenge today is what be tomorrow the balance between a modern kind of public organization, if we can have one, and these large international, transnational organizations. So the challenge is something like, this is a brief sketch of a modern public organization. We have some of that in our primary care reform in Portugal. So part of our system, in fact, changed out of the usual bureaucracy to a more person-associated, decentralized, autonomy, responsibility kind of organization. So the question is, again, is what will the balance 5 years from now between our ability to promote new kind of organizations and the expansion of these transnational private organizations? That's the issue that we need to discuss, need to have answers, need to understand publicly. So let me go now to the last part of the presentation with the 2 dimensions that are left. First one is, what is the context of our system? If I can describe our system on the basis of the 4 dimensions, what is the effect of the context, the social, political, national, international context in our organizations? That's what we mean with context. And I'll touch upon specifically one point. And this is the following. In the last 30 years, we moved from productive economies to financial economies. And that's very important. These financial economies are very different from the old productive economies. And the post-war organizations, whether European organizations or United Nations organizations like WHO, have not yet adapted, didn't find a response to this kind of society, new kind of economic environment. And we are suffering from that difficulty in adapting to new times. How do we suffer? Well, it's easy to summarize it. You know, what we expect for government is a balance between financial, economic, and social policies. A balance. Each one should relate to each other in a way that's acceptable balance of public policies. Now, when you get enormous pressure from financial economists, that balance is broken. And instead of a balance, you get an hierarchy. You get financial sovereignty, financial first, economic growth later, well-being, hope for the best. And of course, that lack of harmony, that loss of harmony from a balanced public health approach to a hierarchy has enormous effects over health and health systems. And I can summarize this in this way. Now, the issue is important because we know now what can be the health effects of austerity over the last 5 years, 6 years. But the question is not that. The question is that we have the obligation today, under current financial and economic policies, to anticipate the effects of health 4 years from now. There's no excuse of not doing it. Unless we anticipate the health effects of current policies in the future, we are not being able to discuss them and not able to minimize the negative effects of the financial economy of our well-being. So I'm almost finishing. My last dimension has to do with governance and government. Well, this could take us the entire night. I don't want to hear the entire night. So I selected 2 points, basically to illustrate how we can look at a provocative way at government and governance in our system. First of all, we have to look at our stakeholders. We fail usually do that. We believe the stakeholders are there. They are quiet, like Indians, right? They're waiting for our command, and they will do what we want to do. They don't. Stakeholders have their own agenda, their own philosophy, their own feelings, their own understanding of the system. So let me present my stakeholders to you, right? Professionals, managers, technical people, academics, social sector, entrepreneurs, investors, journalists, and politicians. Now, unless we understand how these people think about the system, how they expect from the future, how they react to the proposals of policy presented to them, we are not able to manage the system. They are so important. We took them a passport photo so we can travel with them. And let's give you a quick example of our primary care reform. Now, we started a few years ago a very interesting primary care reform based on small decentralized teams that are contracted and financed under contract, and they have a large amount of economy to operate under contract, right? Now, when the reform started, and the green is happy, red is unhappy, right? You see everybody's happy. Professionals were happy. People were happy. Politicians and the media were excited. And academics were happy because it was a rational sort of approach. Now, who was unhappy? Well, basically, the managers of the system, the managers of national, regional, and local national health service, because they were unhappy because they lost power. It was transferred to the periphery, and they were very unhappy. Now, then we changed governments. The new government still supported that policy, but less enthusiastically, because it was a policy of the old government, and you know how it works. Media was not excited anymore, was not used. Then, because political support was not very large, the reform went slower, and as it went slower, people that were not yet part of the reform was saying, the reform never reaches us, become unhappy. And academics are then unhappy because many decisions were taken. They have no evidence base at all. So now there's a new government, and this will change again. Right. But we need to follow the actors who understand what they expect and how we can work with them to make sure that reform happens. Reform doesn't happen from the top. It happens when the local leaders actually want it to happen and get enough support to do it. Now, let them finalize with plans. Our culture is full of plans. Most of our plans are paper, which means do not influence anybody. And I can give you endless examples of plans across Europe, including the European Union, that are just paper. If you go around and ask people, do you know the plan? Some say yes. Have you read it? Many didn't. Have it changed your life in any way? Didn't change anything. So it doesn't exist, it's paper. So we need to go from paper to action, and that's what collaborative intelligence is about, is to allow us to go together toward action in an intelligent way. Now, let me give you a final example, illustration, a metaphor about paper and plans. There is a known artist that lives not far from me. He lives around 3 or 4 kilometers from me. He goes around the world scratching walls and developing art in walls like that. The middle one is his own self-portrait. It is called Vils, also known as Alessandro Farto. And a year and a half ago, he did an exhibit in downtown Lisbon, and he called Dissection. So one of his pieces in this exhibit was a carriage of Lisbon Metro, right? So he took that carriage from his living environment in Lisbon, took it out, cut it in pieces, as you see, and then painted all the pieces in white, and it transformed it in an art object, as you see there. Now, people went around the exhibition looking at this strange metro carriage hanging from the wall and asking themselves, what is that? Now, I'm sure that happens to you often when you go to exhibitions, you don't understand what you see, right? You have to make an effort to understand. That's art. You have to interact with the object of art. Now, if you don't manage to interact, you always a solution. You read the catalog, right? Now, if you read the catalog of this what catalog, the keywords of catalog was as follows: stereotypes, art of complex realities, fragmentation, inability to comprehend jointly the multi-facets of life, monotony, eliminating differences and specificities, white, absence of memory. So what we need is collaborative intelligence that is people-centered, is value-based, is integrated, and activates the community to think actively and to try to be part of a process of change. In summary, something like this. In summary, dynamic assisted representation, information selected explicitly, validated summaries, and communicating timely and effectively, which means visual thinking, metaphoric language, and oral narrative. Thank you for your attention. Have a nice evening.